My name is Dr. Naeem Majeed, and I am a public health specialist in the Rural Ambulance Service project. I was the lead person who designed and implemented this intervention from the platform of integrated RMNCH and nutrition program of Punjab province of Pakistan. About 15 years ago, in the Punjab province of Pakistan, we did not have round-the-clock obstetric services for normal delivery of women in the rural areas. And at that time, the government of Punjab initiated a new program whereby they made the primary care centers functional round the clock for obstetric care, the basic obstetric care, where normal delivery would happen and initial care of the newborn would happen. And by the year 2007, around 700 such centers were working across the Punjab province. But there was no means of transport for the women to reach those health facilities. So usually women would have to make their own transport arrangements. For example, hiring a rickshaw or a tuk-tuk. And sometimes they would hire a taxi. Sometimes they would even use a donkey cart or even maybe travel on a motorbike. So it was quite challenging for women, especially in the late hours at midnight, when usually the deliveries happen, to reach the health facilities. They were still reaching, but it was quite terrible for them. It was very difficult for them. So at that time, the government thought of providing them a transport solution. In 2016, the government of Punjab initiated the procurement of these ambulances. They procured some small vehicles and they were converted into ambulances to transport the women. And then in 2017, this rural ambulance program was launched. And this program includes picking up the woman from her doorstep at the time of delivery, taking her to the primary care facility. And then if there is a need for further referral, the same ambulance would carry the woman to a secondary or a tertiary care hospital. Before 2017, the government had another ambulance program by the name of Punjab Emergency Services, or the Rescue 1122 as it is very commonly known. So that ambulance service was at that time limited to urban areas, one thing, and the other, they were more focused on emergencies. For example, road traffic accidents, cardiac arrest and other similar like heart attack and any other emergencies which were health related, not the normal labor or a woman who would need the ambulance for a non-emergency. It is an emergency, but they would not consider it an emergency. There were two issues. One was that the service was not available in rural areas. And secondly, even if it was available, they would not provide services for such transport. Because the ambulance services were not available at that time, so women had to arrange on their own. So sometimes they would arrange a rented vehicle or a motorbike or whatever, or maybe they would decide not to go because, like, if at 2 a.m. in the night they need they need to go to the health facility for a delivery, they would obviously not go because they won't have any transport to go there. And secondly, even if they would arrange some transport, they would have to pay for it. So sometimes they won't have the funds or the money to arrange that transport. So even then they would decide not to go. Sometimes even a complicated pregnancy would happen and there is massive bleeding, for example, like postpartum hemorrhage, or there is an obstructed labor. And the woman would be stuck and she would not be able to arrange the transport and the health facility or the healthcare provider who is available with her at that time. They won't also be able to arrange the transport. So many of these women would ultimately end up into mortalities, or if not mortality, at least a morbidity, and that the child's health would be damaged or the mother's health would be compromised. Another important aspect of this rural ambulance service was that it was an outsourced service. It was managed through a third party. Previously, the government ambulance service would be run by the government itself, and there would be major issues of vehicle maintenance, the availability of fuel, availability of driver. In this program, the rural ambulance service, we decided to outsource these operations of the vehicles to a third party. So the third party would be responsible for provision of fuel, driver, and a ready to drive vehicle round the clock. So this was a very successful model because the government had been struggling to run an ambulance program on their own, but it was never a success until it was outsourced. So this the model was operated through different third parties. Like the operations of the vehicle, they were run by a vehicle rental company, and then there was a call center. So the call center was centralized. It still is a centralized call center, which is located in Lahore, the capital of Punjab province, and it has a dedicated helpline, which is a toll free number of 1034. So women from across the Punjab can call this helpline, and a nearby ambulance is assigned to them based upon their geographic location. This call center has a functions around the clock, and they have a real-time dashboard in which they can see the actual positions of the vehicles as well as the locations of the callers. So they would coordinate and assign the nearby ambulance. So this one cellular company was running the operations of the call center, while the operations of the vehicle are being run by a vehicle rental company. And the government is basically just managing the contracts and providing them guidance on what services they need to provide, how they need to provide, and paying them for the services. But the services are provided by the third parties. So this system has been really impactful. And when it was started in 2017, we had around 220 ambulances. Then around 250 more were added in 2018, 2019. So we had a pool of 480 ambulances by the start of 2020. And then there was a shift of the government as well. And since this was an outsourced project, so there were a lot of concerns and apprehensions about why a third party is running a government's vehicle and why the government is paying them a huge amount every year. So there was a lot of scrutiny as well of this project, and ultimately they found that it is really cost effective, and the government decided to continue it and sustain it from their own budget, and now it is regularized. So since 2021, the funds for this ambulance service are coming from the regular budget of Government of Punjab, and the project is running so successfully that since the inception till today, they have transferred over 3 million pregnant women from their household to the primary care level or to the secondary level. And out of these 3 million, at least 500,000 women are those who are transferred from primary to secondary level or to tertiary level. And this means that out of these 500,000, these were the high-risk cases who, if there was no ambulance service, may have died or ended up in a severe morbidity. This program, I feel they have empowered the women, because the women, they can now call the helpline from their own home, from their telephone, mobile phones, and the ambulance reaches their doorstep. So they don't need any male caretaker to be present all the time with them to go transport. So even if the males are busy doing their work out in the fields or on their jobs, so even then the woman can go with, the pregnant woman and her sister or her mother or her mother-in-law, they can accompany, and only the woman they can go. Otherwise, before this ambulance service, at least one male attendant would be needed to go accompany them, at least to reach the health facility, and then he could go back. This has empowered the women and also enabled them to access quality health services at a government health facility. Yeah, despite all these successes that I have mentioned, obviously every program has its own challenges and difficulties, and this one also has. One of the challenge which we have started realizing now is that the drivers of these vehicles, they are males, and he is the only male person, while the woman and the people accompanying her, they are usually women. So sometimes I feel that there might be some women who would be reluctant to use this ambulance because the driver is an unknown male, not from their family, and she's pregnant and in a vulnerable state. So she might not be very comfortable. So for this challenge, the government is thinking now of trying deploy some female drivers as well to see how it works, and if it is successful, maybe one day they would have all female drivers in all the 600 ambulances which are on ground today. The other challenge which I feel is that the women, they sometimes at midnight or at late night, they are going to the health facility. So the attendants who are there with them in the vehicle, they are not medical people. They are usually relatives or some community health workers, which are known as JD health workers in Pakistan. So they accompany them. They are not very well trained to handle the emergencies. So maybe there is some sudden bleeding, or even sometimes the delivery may start while or they are en route. This would be a challenging situation for the women, and this is something which the government is also again thinking of deploying maybe some trained healthcare providers who would be present throughout the journey, so that if there is any emergency during the travel, so it can be handled. My key takeaway from this whole implementation experience of the rural ambulance services, there are three different things. One is that the outsource model is, I believe, very successful, and the government should preferably outsource the thing which they are not very skilled to do. Because, for example, the running of vehicles by a health department, which has an expertise in health but not an expertise in running the vehicles. So it is something which they outsource, and it was managed very successfully and very cost effectively. And secondly, I think there was a lot of use of technology in this whole project. Like they were tracking the vehicles, tracking the patients, whether they reached the health facility or not, when they received, how much time was spent during the travel, how much time the driver took from receiving the call to reaching the home. These are the things which were very closely monitored and tracked through digital solutions. And I think that was a reason for success of this program. And I think all the community programs should use digital technologies as much as possible. Well, I feel really proud that I was among the core team that designed this project, and there was a lot of flexibility provided to me by my supervisors and seniors, and they allowed me to pilot and test out whatever I thought would be beneficial for the general public. Feel really proud today that when we started, there were just 220 ambulances and just one or two calls per ambulance per day. And today there are 600 ambulances funded by the government and running round the clock and providing amazing services.